Now guys, let us talk about the development of the midgut. On our last video, we spoke of the development of the foregut and we are done with it. Now, the midgut, if you remember very well, I said it extends from the caudal limb of the diverticulum of the lung of the liver, which we say the liver bud, caudal to the liver bud, up to the junction between the proximal two-thirds of the transverse colon and the distal one-third of the transverse colon. Now, let's take a look at the derivative of the midgut. The midgut is going to form the distal part of the duodenum, the small intestines, yes, including the duodenum, right? So we're gonna form the duodenum, the jejunum, the ileum, but the duodenum will be the distal part of the duodenum. Will form the cecum, the appendix, the ascending colon, up to the proximal two-thirds of the transverse colon. What supplies the midgut? We said is the superior mesenteric artery, which can also be called the cranial mesenteric artery. Superior mesenteric artery is the same. Right. So I want you to understand that your midgut is going to proliferate. When it proliferates about the axis of the superior mesenteric artery. This is your superior mesenteric artery. So it forms a cranial limb, this one, and a caudal limb, this one. Cranial limb, this one, caudal limb, this one. So, due to the increased size of the liver, remember the liver it's a organ responsible for hematopoiesis in utero. So it's gonna be occupying about 10% of the total fetal weight. So there's gonna be pressure within the abdominal cavity. So this pressure is gonna cause the loops to herniate into the umbilical cord. This is called physiological herniation. Physiological herniation. So physiological herniation, it occurs at about week 6. Take note, week 6 physiological herniation. So you start to have the cranial limb going in and then the caudal limb follows. Take note of this. During this physiological herniation, there's going to be a 90-degree rotation. A 90-degree counterclockwise rotation. So they're going to enter the umbilical cord while they are rotating a 90-degree anti-clockwise. Anti-clockwise in this direction. So they will rotate anti-clockwise getting into the umbilical cord. You understand? Good. And then after 10 weeks, the liver is going to decrease its size, become smaller, causing the abdominal cavity to have less pressure. So there's going to be what you call a retraction of the loop. Retraction of the loop. This happens at during the 10th week. of uterine life. So what happens now? I want you to take note of this. When we are now retracting these loops, there is going to be another rotation and 180 counterclockwise rotation. These limbs retracting back into the abdominal cavity. If you remember very well, failure of the retraction of these loops will lead to omphalocele. Omphalocele. I'll talk about it later. But just understand that, is it? So therefore, the total rotation of the intestinal loop is going to be 270 counterclockwise direction. That is in physiological herniation plus in reduction or in retraction. Right. During retraction, you're going to have the cranial limb retracting first, going to the left, and then you're going to have the caudal limb, right, retracting at last. That will be having what called a cecal bud, and then will sit on the right, below the right lobe of the liver. Right. So you can actually see the coiling of the upper or the cranial portion, right? And then now you can actually see the retraction. The cranial portion moves to the left and forms your small intestines. The caudal limb, right, move to the right and it will be below the right lobe of the liver. So there's gonna be a bud called a cecal bud, and that cecal bud is gonna be below the right lobe of the liver. Then on the cecal bud, there's gonna be elongation of the ascending colon. So the ascending colon will shift the cecal bud into the right iliac fossa. That's where you find your cecal bud. And then retrocecal, in the retrocecal position, you're going to have another bud that's going to protrude that becomes your appendix. Your appendix. You understand? Good. So let's now take a look. We said rotation of the midgut. The midgut rotates 90-degree counterclockwise about the axis of the superior mesenteric artery. That is physiological herniation at day number 6. During rotation, the midgut forms the loops, right? Forms the loops, which is the cranial part. That's the one that's going to form the jejunum and the ileum. Now, we are going to have a retraction of the midgut. So the retraction of the midgut is caused by the decrease in the size of the liver and the kidney and the enlargement of the abdominal cavity. So there's going to be less pressure. This retraction is going to take place around which week? Week 10. Remember. Good. So as the large intestines retain, they undergo a 180-degree counterclockwise, making the total rotation 270 degrees. Take note of this. The cecum will retrain last, and it's going to be located below the right lobe of the liver. And there's going to be elongation of the ascending colon, which will shift the cecum to be located in the right iliac fossa. So you can actually now appreciate and appreciate and appreciate and appreciate. Right. So this becomes your transverse colon. This becomes your greater omentum. Remember, that is going to be fused with the transverse dorsal mesentery of the mesocolon of the transverse colon, called the mesocolon of the transverse colon. Right. What can go wrong with the formation of the midgut? Take note of this. There is what we call Meckel diverticulum. So Meckel diverticulum is just a bud connecting to the umbilicus, right? Like this. This is your umbilicus, and you have a bud. And this bud, it occurs at the antimesenteric border, which is not here. This is the mesenteric border, where there's the superior mesenteric vessels, right? Then the side that is opposite, that is no superior mesenteric, is called the antimesenteric border. So this bud, the ilio diverticulum or the Meckel diverticulum, it occurs at the antimesenteric border and attaches to the umbilicus, right? What is important is this abnormality. It may occur in 2 to 4% um, of fetus, and it can be found moving starting from the ileocecal valve. It can be 40 to 60 centimeters from the ileocecal valve at the antimesenteric border. What is quite interesting about the Meckel diverticulum is that the tissue in the Meckel diverticulum can actually be histologically the same as the tissue in the pancreas. So you can actually see this tissue being able to produce digestive enzymes because it will be the same as the tissue in the pancreas. So that's everything that I have for the formation and the development of the midgut. Thank you so much. Take care.